Hey everyone, welcome back to another PS Platypus lecture. Today we're going to be focusing on the physical examination of the respiratory system. Before we begin, I just want to let you know that whenever you discuss something in clinical skills, whether it is a history, whether it's an examination, whether it's something procedural, it's really important that once you've learned it, you try and get some practice in with either your friends or your family as consistently as you can. And I know that that can be quite difficult, especially if people might not be available to perform these things on, or during COVID, it's very difficult to actually meet up with people in person. But as much as you can, try and practice this, even if you have just like a stuffed toy or something like that, just to practice on. Try and get that in as much as you can, because what you'll find is if I go through this presentation now, and I've simplified it as much as I can, but even then, it can be really difficult to retain a lot of this knowledge for the long term unless you actually physically sit down and perform it on someone. That's what I found this year is that, last year I kind of had a general understanding about how these examinations work. But if you were to ask me, I wouldn't have been able to run through the whole thing very accurately. This year, though, while I'm in the hospital, because I've performed these examinations on multiple patients, I've kind of found that, subconsciously, all of these things exist. And if someone was to ask me now, I probably will be able to run through most of these things quite well. And that's not because I've sat down and memorized all these things. It's just because I've practiced them quite a bit. So with that out of the way, and hopefully that makes a bit of sense as to why I'm suggesting this technique, we'll get into the general overview of what the respiratory examination looks like. Now, for those of you keen beans who've seen the cardiovascular examination video that I posted last year, you'll notice that the structure of the resp exam is exactly the same. Obviously, the only differences you will be seeing are going to be the actual specific signs you're looking for in, for example, peripheral examination, as well as when you get to the chest, you're not focusing on the heart anymore, you're focusing on the lungs and the airways. So just keep that in mind. But overall, you've got four major steps. You've got general inspection, plus or minus vital signs if you have time, peripheral examination, and then you've got the chest exam. All right, so when it comes to doing this examination, obviously, first of all, it's really a good idea to introduce yourself. Who are you? Why are you there? Where are you from? Monash University, whatever it is, you're a second year medical student. Obtain consent from the patient, and probably before that, explain to them what you're going to do to them. So explain, I'm just going to have a brief look at your hands, your face, your neck, your chest, and potentially your legs. And then I'm going to listen to and feel your chest more specifically for lung pathologies. So once you've said that, ask them, is that okay? And they'll say yes. And then explain to them the exposure that will be required. So for steps 1, 2, and 3, there's no real exposure that you will need because everything is peripheral. Once you get to step 4, though, you may need to explain to the patient that you will need to see their chest in full visibility. And obviously, in a male patient, that might be okay. But in a female patient, you can still have the patient having their bra on if they so require. All right, so when it comes to general inspection, you're first looking at the mental state of the patient. So are they in any agitation for any reason? Is there any pain that's visible or any discomfort? More specifically for resp exam, you're looking for signs of respiratory distress. So if their lungs are not working properly, you will see all sorts of extra bits and bobs coming in to try and compensate. So accessory muscles, especially in the neck region, you might notice that like if I'm breathing normally, I've got my diaphragm helping me. But if the diaphragm is either not good enough or like it's not working properly, or if you've got such a severe pathology that the diaphragm just has too much workload on it, it will try and recruit some other muscles. So for example, neck muscles here, you might notice the patient will sort of look like this. So like really tensed up, contracted muscles in the neck, because those neck muscles are actually allowing them to breathe a little bit easily. You might also see nasal flaring, so their nostrils becoming really wide because they're trying to get more air in. Audible wheezing or stridor could be early acute signs of some sort of obstruction. So classically asthma or COPD. And then an audible cough. So is it a wet cough or a dry cough? Can you notice like a bovine cough? So does it sound like something specific that could be underlying pathology? And generally these coughs are due to some sort of infectious cause, but not always. So just keep that in mind. In terms of body habitus, do they look abnormally thin? So cachexia. Are they in some sort of strange posture? So a classic posture that you might hear about with COPD is called the tripod position, where they sort of lean forward and you can't see the bottom half of my body, but you've got your hands planted firmly into each of your legs, and they're just going forward like this and trying to really deep breathing in. You'll see the accessory muscles. That's a classic picture of COPD. And there's also others that you can look up. And then deformities. So there could be deformities that are completely unrelated. So like a fracture of the arm, right? That's not really respiratory related, but still note it down. You might notice deformities of their spine or deformities in their chest wall, which we'll get into once we get to the precordium. But if you can see those from the get-go, it's a good idea just to tell the examiner that you can see them, as well as external things around the patient. So always never forget the surroundings. So do they have breathing aids like an oxygen mask? Do they have a sputum mug near them? And usually if you see a sputum mug in the hospital, you would want to actually look at what the sputum mug has inside it so that you can comment on it. And then inhalers. So are they using things for asthma or COPD? Perhaps asking them like, is it something you're using regularly, just to make sure that they are consistently applying those inhalers. When you get to vital signs, there's no real like specific vital signs that you need to be thinking about. Just do all of them if you have time. But the main ones that are relevant to the respiratory system would be the respiratory rate. So is it really elevated, which is called tachypnea? Is there a high temperature? So do they have some sort of fever? And is there a decreased oxygen saturation? So that would be hypoxia. That can give all sorts of evidence for the underlying respiratory pathologies that this patient might have. All right, so let's get to the important stuff now. When we get to the peripheral examination, we start off with the upper limb and we just simply ask our patient to put their hands in front of them and allow us to inspect. You also want to do both sides, not just one. So looking at the nails, you're thinking about firstly clubbing. Now, for the keen beans that have already seen last year's cardiovascular examination video, you will remember that clubbing is a sign that you see in conditions like infective endocarditis, but also more commonly with congenital heart disorders. However, it's not specific to cardio. You can also get respiratory signs. In fact, I believe respiratory signs are a lot more specific for clubbing than cardiovascular is. It could be a sign of chronic hypoxia due to a number of conditions, but never ever say that clubbing is due to COPD. Now, I couldn't really tell you why you don't see clubbing in COPD. I guess it's just a fact, or you can search it up and let me know what you think. But if someone comes up to you, whether it's your lecturers, teachers, a consultant, and they say, oh, what are the causes of clubbing in a respiratory context? You can name a bunch of things, but just never say COPD. When you get to the nails as well, you want to look at the nail beds for signs of peripheral cyanosis. So is there any bluing, which could be obviously a sign of hypoxia, but also peripheral vascular disease, which is a bit more cardiovascular related, and heart failure. Remember, heart failure is not just a cardio condition. It originates in the heart, but also it will cause signs and symptoms in all sorts of systems, especially rest, because you can get fluid overload. In the fingers, you're looking for tar staining. So in the fingers, as well as between the fingers, you might notice those tar stainings, which is a sign of them currently smoking. You may want to look at their palm as well for muscle wasting. And you're specifically looking at the hypothenar eminence. And the reason why is because remember that those muscles in that bulk on this sort of side, on the medial side of your hand, they are innervated by the ulnar nerve. And just if you think about it really generally, that's going to be like the C8T1 group myotome. The C8T1 would be the bottom half or the bottom level of the brachial plexus, which is anatomically very, very close to the apex of the lung on whichever side. So if you have a apical lung tumor, so on the apex of the lung, you have a tumor that's gradually growing, it might impinge on those nerve roots, C8T1, and lead to denervation of the muscles in the hypothenar eminence. So you might get wasting of that muscle bulk. At the wrist as well, if you ask the patient for both of the wrists, if you just like squeeze on both sides like this, squeeze on both sides very lightly. If you get some sort of tenderness, HPOA is not the first thing you'd be thinking of. Probably the first thing you might think of is, oh, does this patient have a fracture of their wrist or something really common? And then the worst case scenario is that this is actually a sign of HPO, which is hypertrophic pulmonary osteoarthritis or osteoarthropathy, which could be a sign of lung carcinoma. But you don't want to say that in front of the patient because, again, it could be all sorts of things, even just like general inflammation around the wrist. So just note it down. And if you're relaying this information to the examiner, say that this might be something to rule out if it is a lung carcinoma. And then you want to do some dynamic tests. So things where you'll actually have to get the patient to move a little bit. So if you get the patient to just put their hands out in front of them and assess for fine tremor, so extend your arms out as far in front of you as you can, hold it there for 10, 15 seconds. If you notice that there's a tremor like this, again, there's a couple of other systems that this could involve. For example, classically, it can be hepatic encephalopathy, where they get sort of tremors again. But in the case of respiratory exam, it can be something quite benign, which is just them using a lot of beta agonist medications for their asthma or COPD that can cause the tremor. Classically, also, if you can't see a tremor, it's a good idea just to get a piece of paper and put it on top of both these hands. And if you can't visibly see this hand tremor, you might notice that the paper actually starts to get a bit of tremor in it. And that can be a sign that they have this beta agonist overuse. Asterixis is the same thing, but okay, you get them to extend their hands out and then cock their wrist back like this. Hold it there for about 10, 15 seconds again. I think some textbooks say hold it for a minute, but of course you might not have that time. So cock their wrist back, extend their hands out. If you notice that their hands start to do this, so like pumping back and forth like this, then that could be a sign of severe CO2 retention in a lot of obstructive conditions. Again, it could be a sign of some gastrointestinal pathologies, which we will see when we get to the gastro unit. But in this context of RESP, it is CO2 retention. And then Pemberton sign. So if you get the patient to raise their arms up above their head like this and hold it there for a couple of seconds, so maybe 20, 30 seconds, then a positive Pemberton sign means that they'll get flushing of their face and a couple of extra things, but the main thing is respiratory distress. So why do you get these signs? Well, if you have some sort of obstruction around the level of the superior median sinum, the neck area, classically it's to do with like a goiter, so a thyroid that's been enlarged, but it could be a lot of things like even cancer that's growing around the region. If you get that sort of pathology here, then firstly, the superior vena cava is not going to be able to drain a lot of the blood from your head and neck. So all that blood is going to pool here and you'll get redness. So that explains the redness and the plethora that you might see. But when it comes to the respiratory distress, I think that one is a bit more obvious because what's happening is that you get obstruction of the trachea. So less air goes in, the patient starts to panic and their body kicks in and you get all the mechanisms like the extra muscles starting to be used. They're going into tripod position, all that sort of stuff starts to be visible. So Pemberton sign is just a general sign that is for obstruction. And in that case, you want to be really careful that their airways are not being obstructed because that will cut off any oxygen to the rest of their body. All right, when we get to the head and neck, it's very systematic. So first you start with a broad picture of their face. So if you see any gross redness, so what we call facial plethora, I already mentioned SVC obstruction. So one of the cardinal signs that is responsible for the Pemberton sign, but also it could just be chronic smoking, which will cause vasodilation in the arteries and veins of the face. Sinusitis is a really good one. So inflammation of the sinuses secondary to potential respiratory infection. So you want to be palpating some of these major sinuses. So you'll learn about this in head and neck more, but the frontal sinuses sort of up here, you might be able to palpate those on yourself right now. Maxillary sinus sort of here. Palpate those if you notice any tenderness on the patient, then that can be a form of sinusitis. Around the eyes, and I might take off my glasses for this one, you're looking for two main things, which is jaundice and anemia. The way to do this, and you would have done this in cardio exam as well, the way you do this is first you ask them to pull their upper eyelids up like this. Hopefully this doesn't look too scary on the camera, but you have the upper eyelid pulled up, get the patient to look down like that. And you will be able to see the whites of their eyes quite clearly when they do that. But if you notice that they're not white anymore and they've become yellowed, that's obviously a sign of jaundice. If you do the same thing like this, so pull the lower eyelids down and get them to look up this time, you should be able to see this nice pink conjunctiva in the inferior part here. If you notice that that conjunctiva has actually become pale, then that can be an early sign of anemia because that tissue is not being perfused with the really healthy red blood cells. I might put my glasses back on. Then you've got Horner's triad. So Horner's syndrome has 3 classical symptoms associated with it. And it can be due to an apical lung tumor, but there's actually multiple causes, which you will go in. Like you might have gone through the apical lung tumor aspect of it in rest, but you'll go through the other causes when you get to head and neck. The classic signs, though, are ptosis, anhydrosis, and meiosis. So the way I remember this is PAM, so PAM. So ptosis, and this is usually only unilateral. So if you've got like an apical lung tumor here, and it's compressing some of the nerves that are going up to innervate the like that half of the face. These are typically the sympathetic fibers. It'll stop all of these 3 functions on just one side, not both. So if it was on the left side, I might see left-sided ptosis, which is the eyelid drooping on the left side. You might see anhidrosis, which is a complete lack or reduction in sweating, because again, sweating is a sympathetic response, and meiosis. So remember, sympathetic response wants you to open up your pupils as much as possible. If you cut off that sympathetic response, you will get really strong constriction of the pupil. So those three signs combined gives you Horner's triad, which is a really big sign that you don't want to rule out an apical lung tumor. And of course, if you see this in conjunction with some of the other signs we talked about that are pointing towards lung tumors, then that will strongly support that as a potential provisional diagnosis. Then you want to look at the nose. So the way I do this is I get the patient to sort of look up as much as they can, and I'll get a torch and shine it into their nose, or you don't need a torch, doesn't really matter. Depends on how much detail or time you have. So you look for a deviated septum, which could be the reason why they're having some sort of respiratory problems. Polyps, which can be an early sign of, I believe, asthmatic changes. And then turbinate being engorged, so a sign of infections. In the ears, you're looking for, again, infections. The reason why is because the ears are connected to the upper respiratory tract anatomically. And you may have covered this in resp anatomy, but you will definitely cover it in head and neck. And then you've got the mouth. So remember how in cardio, we looked at dental hygiene. So get the patient to smile with their teeth, and you'll be able to see their teeth and how well maintained they are. Get them to open their mouth as wide as you possibly can. Get a torch if it's not well lit, and look for things like a crowded oropharynx, which again could be obstructing the flow of oxygen into their body. Then you've got central cyanosis. So as opposed to peripheral cyanosis, this will be mainly around the tongue and the mucous membranes. So a sign of hypoxia. And then signs of upper respiratory tract infections. So enlarged tonsils and pussy exudates that you might be able to see around the mouth. All right, when you get to the neck, there's a couple of really important things to look out for here. And these are sort of red flag signs. So be sure not to rule them out. So in the trachea, the two things that you want to look for is tracheal tug. So if you just see the trachea and maybe just like use your hands to feel for it, just ask them to sort of breathe in and breathe out as deep as they can. If you notice that when they breathe in, the trachea sort of just displaces downwards. And it's kind of like, okay, if I breathe in, I would expect that all of this stuff would sort of move up with my breathing. But if it just gets stuck near the bottom, and so my whole body sort of goes up, but the trachea just stays there or it moves down, that can be a sign of really, really advanced COPD or fibrotic changes around the lungs, which is actually like all those fibrous tissues actually just keeping the trachea placed specifically rather than allowing it to move. Then you can have deviated trachea. So normally the trachea should be midline, and the way that you can measure it obviously is just feel for it with your fingers like this. Is it around the middle? Yes, it is. That's fine. You can have deviation, and you want to be thinking about a couple of really important things, which is it ipsilateral or contralateral? Now, of course, without a reference, you won't be able to tell whether it's on the same side or to the opposite side of the pathology. But the reason why I put that in there is because when we get to anatomy of the lungs, you may notice that, for example, if I have lung collapse, so say on the left-hand side of my body or the left lung is collapsed, what will happen is because it's collapsed, you will get there being more space on the left-hand side. So the right-hand side lung might actually shift towards a bit more to the left side, as well as the trachea might shift a bit more towards that left side. So because you have left-sided lung collapse, you will have ipsilateral tracheal deviation. So it goes to the same side. So the opposite is something you might see with tension pneumothorax. So say on my left-hand side, I've got a really acute buildup of air, and it's a tension pneumothorax, meaning that all that air is just getting trapped and none of it's been able to escape. So a lot of the mediastinal contents, which is around the chest region, will start to get pushed to the opposite side because this side is being filled up with air. So you will get the lung being pushed to that side. You will get the heart as well being pushed to that side. Everything will be pushed to this side, including the trachea. So that is left-sided tension pneumothorax causing contralateral tracheal deviation. So just you want to be thinking about these things. If I have tracheal deviation in a patient to the right, could there be stuff happening on the left, or is there stuff happening on the right, and what could they be? Then you want to look at the JVP. Raised JVP is classically a sign of overload in the left atrium. Sorry, the right atrium. You have some sort of overload. And this could be a very important sign for the resp context of cor pulmonale, which is basically some sort of problem in the lungs which is causing a backflow of blood and therefore causing overload in the right atrium, which is then backflowing again into the JVP. So you can have a pulmonary embolism, you can have fibrosis of the lungs, and so on. And then you want to be looking for lymph nodes. Now, this is not a hugely important thing that came up for cardio exam, but for resp, it's very, very important, because if you have infections around this respiratory system, then you might get that, or like the infectious agent starting to spread through the lymph nodes, and they will become inflamed and tender. Also, you can have those lymph nodes becoming really hard or even rubbery, and that can be a classic sign of cancer, especially if they're non-tender. That will most likely be either from a primary lung cancer or lung tumor that has metastasized through the nodes, and you might be able to palpate them around the head and neck region, or they can be secondary metastasis from other organs. And the lung just happens to be one of those organs that is able to capture a lot of these secondary metastases. So these are the main lymph nodes that you want to be thinking about. And I recommend starting to memorize these or remember these as early as possible. If not the names, at least where to locate them, because it'll serve you very well for next year when you're asked to do RESP exams on the wards. So I have a diagram on the next page, which kind of has all of those lymph nodes labeled on them. But I thought instead of just showing you a diagram and moving forward, I thought I'd just really quickly run through them and the way that I like to think of them very, very easily. So this order here is going from the chin all the way across like posteriorly and then down to the neck. So submental would be here. So if you just need to sort of feel around here. Can you feel a lymph node? By the way, lymph nodes you shouldn't be able to feel normally. So if you just do this and you don't feel anything, that's fine, that's normal. If you feel something, then there's a problem. So submental is here. Submandibular would be sort of around here. So if you kind of think about the mandible, so the jaw sort of there. Tonsillar would be sort of here. And again, I'm doing it on both sides. So this is tonsillar. Then you've got pre-auricular and post-auricular. So before the ear, after the ear. So before the ear would be just there, right? So again, on both sides. Past the ear would be behind, just behind the ear. You might also think about the parotid lymph nodes, so just like on the parotid gland, but it's not something we'll talk about now. Occipital is just the back of the head, sort of here. I'm not sure if you can see this, but it's going to be here. Then you've got the cervical chains. So superficial cervical, you can sort of just feel, if you think about the sternocleidomastoid muscle, which you will cover in neck, if you can follow that or track that along, just like on the anterior side, that's going to be sort of the superficial group or superficial chain. The deep one, you actually sort of have to dig underneath the SCM muscle on both sides, and you should be able to feel, obviously you shouldn't be able to feel them, but if you do feel anything, those will be the deep cervical lymph nodes. And then posterior cervical is sort of behind. So if you think about the trapezius muscle and you think about the SCM, kind of between them would be where you might find the posterior cervical lymph nodes. Supraclavicular is not really RESP related. It's actually more of a sign of stomach cancer if you get a increased enlargement of especially the left-sided node, which is called Virchow's sign. If you can feel it here, so above the clavicle, just there, that can be a sign of potential stomach cancer, which has metastasized all the way up to this lymph node there. So of course, when you do palpate something, run through the basics of actually describing it. So first of all, what node is it that you're feeling? What's the size of that node? How palpable is it? What's the texture? What's the is there any tenderness present? That kind of thing. So that's those lymph nodes there. I think I might just really quickly, so I said the superior cervical is right there. So above the SCM, sort of anteriorly. And then you've got the deep cervical, which is underneath. So you'd have to actually dig deep. Posterior cervical is between the SCM and the trapezius muscle. And then you've got supraclavicular up here, which is a sign of thorax and abdomen pathologies. Now we get to the chest. So you're looking for, first of all, on inspection, you're looking for the shape of the chest. Are there any skeletal deformities? So barrel chest, where you look for the difference in the AP or anterior posterior dimensions of the thoracic wall, as well as the lateral dimensions. So barrel chest means like right now, my AP dimensions, so front to back, wouldn't be as big as my lateral dimensions. If the AP dimensions start to become similar to the lateral dimensions, then you get a barrel shape. That's a classic sign of COPD because of increased retention of air, which is causing things to become hyperinflated. Funnel chest, also known as pectum excavatum. Pigeon chest, also known as pectum carinatum. So either your sternum is sort of pushed inwards for funnel chest, or sternum is pushed outwards for pigeon chest. A lot of the times, these are just congenital abnormalities. But if they exist, that can mean that you can have some sort of issues with breathing, especially if things are pushed inwards. And then Harrison sulcus. So it's like generally described as a linear depression underneath the ribs, so underneath the lower ribs. I've never seen it, but allegedly it's a sign that you will see more with people who haven't been able to control their asthma very well, especially in children, I think. For the skin, you're looking for general things like swelling, redness, rashes, any surgical scars that they may have had. And then we're kind of delving into palpation here, which is feeling for subcutaneous emphysema. So air underneath the skin, which could be a number of things, but it could be that you've got, like worst case scenario, could be that you've got a puncture of your lung and some of that, like a really, really small hole, and that's causing air to come out and then kind of settle underneath the skin. And then the apex beat, again, because I said, you know how if you have some sort of deviation in the mediastinal structures, the heart might also be pushed to one side or the other. So if you notice that the apex beat is deviated, ask yourself, what could be the cause if it was an ipsilateral deviation or a contralateral deviation? And then a couple more dynamic tests. So Hoover's sign, it's very difficult for me to show you now, but the way that we do this is that if this is the patient in front of me and I'm facing their back, if I put my fingers like this around their sides, so my thumbs are here, and they should be equidistant from their spine, ask them to breathe in as deep as they can and then breathe out. What you'll notice when they breathe in, their thorax sort of expands outwards. So you'll notice that your fingers kind of go like that. And then when they breathe back in, fingers will go back towards each other. So you want to look, first of all, is it bilateral chest expansion? Or do you notice that, okay, only one finger moves a lot, which means that this side, something's happening here, which is causing the expansion not to be complete. As well as how far can they expand? So I forget the number, but there is a certain distance that you're looking for. I believe maybe like 5 centimeters or something like that. Correct me if I'm wrong. If it's 5 centimeters, that's normal. If it's less, then that will be some sort of restrictive problem that's causing them not to be able to expand. And then vocal fremitus. So palpate over their lungs, especially when they say the word 99. Okay, if you notice that there's some sort of like, for example, if the 99, or you're able to palpate it really, really well, and it's quite, I guess, like a beating sort of consistency to it, then that can be a problem. But I think I'll explain this a little bit more when we get to auscultation, because this 99 concept comes up quite a bit. Okay, percussion wise, so I'm not sure if you would have covered a lot of percussion with cardiovascular. It's not an important thing there, but for rest, it definitely is. What percussion is that you're taking one hand, putting it on their chest wall, either posteriorly or anteriorly, digging in sort of like one finger, and I like to use my middle finger for that, and then using another hand to kind of tap onto that middle finger or whatever finger you're using. So as you tap, normally, like if you were to practice on an empty box, if you did this on the box, then you'll notice that there's a really light sound, slightly high pitched, which indicates that that box is empty, right? There's just air inside it. If you did it on a box that was just full of stuff, or on a milk carton or something, and then you tapped, you'll notice that it becomes a bit more dull, low frequency. And that indicates obviously there's something inside that is causing that air to be able to conduct through more dense material quite well. So it's kind of a bit of physics, right? Like with air, sound may not be able to go through as well, but when it comes to more solid materials, more dense things, sound is able to pass through much more effectively. So you want to palpate or percuss along a couple of different places. Firstly, over the clavicles, because the clavicles lie directly over the apex of the lungs. So with this case, you don't have to use one hand and then tap on it. You can just tap directly on the clavicle with your tapping finger. For the back, ask the patient to cross their arms in front of their body like this, anteriorly. Reason why is you're moving the scapulae away from the lungs, especially from the upper lobes of the lungs on the back. Naturally, ask the patient to put their hands on their heads, on their head, and that will expose all of the lateral lobes. And then at the front, ask the patient to put their hands on their hips. So that will just mean that this is a bit more flat for you to be able to percuss on. Now, interpreting percussion is very important. If it's resonant, as I said, which is sort of just like a normal high pitch sound, that indicates that there's air. If it's hyper resonant, and of course you will need some sort of I guess experience with what resonant sounds like. But if it's really hyper resonant, so super high pitched, that is basically too much air. So it's pneumothorax, or it can be a sign of COPD. If it is dull, that indicates some sort of solid, kind of like that milk carton analogy that I mentioned. That can be a consolidation, or it can also be a lung collapse. In this case, the lung collapse is kind of like the lung has become deflated. There's no air inside it. So it's almost like it's become this solid mass of just like lung tissue. That's why you get dullness. And stony dullness is a pathognomonic for pleural effusion. In this case, you're thinking more about fluids being involved rather than it being a solid consolidation. And then auscultation. So the sounds that you're listening for, obviously you're using your stethoscope, using the diaphragm of the stethoscope most of the time. Potentially for the apex of the lungs, you might be using the bell because it's a bit more difficult to lodge your diaphragm of the stethoscope there. But you're listening for the major lobes. So remember that you've got lobes for each of your lungs. Left lobe has two, left lung has 2 lobes, right lobe has 3. And it's super important to remember that that is like a normal anatomy, right? So you would realistically only be listening over 2 major areas on the left side and then 3 major areas on the right-hand side from top to bottom. But I think that generically speaking, just to avoid confusion, most of the time, you will get doctors just doing 3 on each side anyways. And I guess it's just for consistency's sake. So listen to all the major lobes of those lungs. Vesicular means it's a normal sound and it's quite soft. It's generally low pitched. Bronchial sounds are normal when you can hear them over the trachea. So this is probably one of those sounds which you'll be able to actually practice hearing. If you put your stethoscope over your trachea and breathe in, that's what a bronchial breath sounds like. If it's anywhere else, then it's pathological. So it's consolidation or a sign of pneumonia. Wheezing is a sign of obstruction that can be just audible, generally speaking, without stethoscope, but it's also quite audible with a stethoscope. So asthma or COPD. Crackles, if you have really coarse crackles, it's a sign of edema in the lungs. If it's fine crackles, it can be a sign of interstitial lung disease. And then a pleural rub, very pathognomonic for pleurisy, so just inflammation of the pleura. Remember, if you have inflammation, they're going to rub against each other, and that's why it's called a pleural rub. It can also be a sign of pericardial inflammation. So you have the pericardial layers actually rubbing against each other. And the way to distinguish those is if you can hear the pleural rub while they're breathing, that's more likely to be pleurisy. If you tell the patient to hold their breath and then you listen for pleural rub, and you can hear it around the region of where the heart is, then that is a sign of pericardial inflammation because the breathing aspect of it is negated. Finally, resonance. So again, that 99 comes in this time, and it's a bit more easy to listen for here, is you put your stethoscope in, patient says 99, listen over all the major lobes again. If you hear things more clearly, it actually means that there's something bad happening. If you don't hear it at all, so like if you just hear or just something really, really faint and muffled, that's fine. If it becomes very clear, like you can literally hear them saying 99 through their lungs, that can be a sign that there's some sort of solid, because what's happening is the sound is going from their voice box down into the solid parts. And because the solid is able to convey that sound, the sound waves a bit better, it's able to be received through your stethoscope and you're able to hear it quite well. So the more clear it is, the worse the consolidation. Also, if you want to be a little bit extra fancy, you can try this thing called whispering pectoriloquy, which is again the same thing, but you just ask them to whisper. And I guess this is just a sign of increased severity. So if they whisper and the 99 is very clear, then that's probably even worse consolidation than with the vocal resonance. All right, so that's it for the respiratory examination. Thanks again for sticking around. Hopefully that wasn't too long. And hopefully I've provided you with a really good sort of framework to be able to practice these things. Again, after you finish watching this, if you can just grab someone who's either living with you or practice via Zoom, running through this whole process so that it becomes consolidated in your mind, so that if anyone asks you, you'll be able to run through it very, very easily. Amazing. Well, thanks again, and I will see you for our next video. Bye.